Hi, I'm Jeff Dreher. I'm an emergency physician and operational excellence leader, and I'm here to tell you about how we successfully removed healthcare's 38-year-old problem, one that's been unsolved for 38 years. And this will improve nursing and staff satisfaction as well as patient satisfaction, increase your hospital revenue as well. I'm excited to show you this. I recently presented this at the TOC Innovation Conference in Las Vegas. This is an excerpt of that talk. And this problem has been going on 38 years. The problem actually began in '87 after reimbursement changed to a DRG based. It actually dramatically dropped reimbursement to hospitals dramatically and made many hospitals run in the negative. And the problem has persisted despite them trying to solve the problem. Many organizations have tried to solve this problem, but it is persisting. In fact, currently 28% of the hospitals have negative operating profit margin. And that's extremely important. I'm going to show you why in a minute. So overcrowding is affecting our staff and our patients. You can see it on the faces of these nurses and doctors where they are just totally stressed and burned out. They have very little downtime. In fact, 60% of all nurses report burnout. 50% of the nurses quit within 5 years of start. That means we have a younger nursing population. When I first started practicing in the 90s, the actual tenure of a nurse was 10 to 20 years. And 500,000 nurses have actually left the profession in the last 5 years. Why are they leaving? Because they have too little patient contact. They went into nursing to actually care for people. That's their passion. However, we have the EMR now and other responsibilities that they are faced with, and this is giving them too little patient contact. Also, the stress of being overworked and working understaffed is also taking a toll. And 80% of the nurses report working short-staffed with inadequate staffing levels. And the effect of waiting for care when you're a patient can have tragic results. This is not infrequently happening in our country. This is a sad case, very tragic case of an 18-year-old high school senior rowing champion who had a full ride scholarship to an Ivy League school. One day he developed a scratch on the back of his leg while rowing, and that scratch worsened over the next 3 days. He went to the emergency department on a Monday where he waited to be diagnosed. 12 hours later, they began amputating his right leg. He had necrotizing fasciitis. This is a horrific disease, and if diagnosed early, may have actually had a better outcome. But he left the hospital 6 months later with no legs. This should never happen to any patient. This is a problem that, if it had been seen rapidly, could have potentially, not required much of an amputation. Who knows? But the thing is dealing with the stress of this, knowing that the system is causing harm to patients. Can you imagine the triage nurse, how she felt when she found out that she missed this in triage? It's crazy what this is doing to our staff. We need to get rid of this overcrowding. And there is a disconnect between the leadership and the frontline staff. The frontline staff are clinically conscious. We're worried about what's best for the patient and quality. But the C-suite is extremely fiscally conscious. And it took me a while to figure out why, but they have been running at low profit margins for many years. And as frontline staff, we're pretty much shielded from this. But this is the root cause of our problem, is a financial issue. Well, it's because hospitals have been running in the negative for the last 30 years. This is the percentage of hospitals with an end-of-year negative operating profit margin. And I know as a clinician, talking about money is really a turnoff for most clinicians, but to be honest with you, we need to kind of understand part of this to understand how we can fix the problem. And during times of stress, it's even worse. During COVID, it was up to 50 some percent. Currently, it's at 37% of the hospitals, of the 6,000 hospitals in our country, have a negative operating profit margin. And it's been very low, 2%, 3.3%, 0.8%. Without margin, hospitals cannot refill empty positions. They leave those positions open. They short staff your hospital. They don't innovate. They don't educate. They freeze hiring. They freeze staffing, and they freeze community services that are very important. So hospital administrators have had to deal with these low profits, and they have had to cut costs, and they've also had to look for solutions. So where did they look to cut costs? How did they make those decisions? Well, staffing is the biggest expense that the hospitals have, 48 to 56%. And the rest of the expenses are kind of fixed. They can't really change the cost of utilities, maintenance, and insurance and supplies. So they look at staffing and they try to optimize staffing, which is causing burnout. What they do is they look at the census and they adjust the number of staff working according to the census. Say we have 300 patients in the hospital, we have a 6 to 1 ratio of beds to nurse, so we would need 50 nurses to care for this. And this drives the hospital occupancy rate up to above 85%. Of all the hospitals I have ever worked in, we have never had an occupancy rate of below 85%. And what does this cause? This has a huge negative impact. It causes waiting. And waiting is the root cause of all of the issues that we're having in healthcare. Because hospital occupancy rate, as it goes above 80%, it causes waiting to become exponential. And this is set in stone. This has been present since the beginning of time. If you increase utilization or occupancy above 80%, wait time becomes exponential. So there's no way that we can solve this in our current system because we have a high occupancy rate of everything. So everything in our system is running at high occupancy. So everything is waiting in a sequence for everything: beds, CTs, labs, staff. And this creates huge bottlenecks in our system. But thankfully, we have found a solution that is common sense and is easily implemented that will remove these bottlenecks and focus our improvement processes on getting rid of them once and for all. So hospitals looked to find a solution and they went to Lean and Six Sigma. And in fact, 75 to 80% of the hospitals currently use this. They're good methodologies at doing certain things. They're good at improving processes, decreasing waste, improving efficiency of things, but they're bad at overcrowding, boarding, and diversion. This is more of a management problem. There are bottlenecks in our system causing this. These are capacity and throughput issues that aren't currently being recognized, managed, and they've been going on chronically for many years. Just ask any ER charge nurse. She'll tell you where the bottlenecks are. And what has happened in our system is that the low operating profit margins have led to them driving the hospital occupancy rate up to be high, which causes things to wait. Patients wait long times in the emergency room for care, and this causes quality issues. And the high occupancy rate causes people to walk out. It causes us to divert squads, us to be overcrowded. And it causes our staff to burn out, working so short staffed. This further causes lower margins. And over the last 30 years, the cycle has just repeated itself with low revenue causing them to cost more, which causes more waiting, more diversion, more burnout. We need to break this cycle. And we can actually make some profits off of our losses. There's a benefit of taking action, and there's also cost of inaction. So patient losses are the biggest. 10 patients that leave your hospital a day without being seen adds up to about $2 million of net profit annually. Net is what is left over after all expenses are paid. The total amount from patient loss is 5.8 million. This is massive. There's also losses from staff turnover, physician turnover, and quality losses. All said, it's about 7 million of net profit. So these are real numbers that can actually be shown to an administrator to help get buy-in for change. We're not going to cost you money. We're going to make money. So I'm going to show you how we can successfully solve this problem by using a combination of theories, TOC, lean, and queuing theory. I'm going to boil this down to a commonsensical approach that is easily understood and easily implemented. So here's the overall framework on how we're going to improve things. TOC is the strategy. It looks at what is the goal and what is the bottleneck. Queuing theory helps you to uncover the bottleneck because it discovers where is the bottleneck and what are the causes of waiting. There's only 5, so you can analyze the bottleneck using those 5 causes of waiting and remove the bottleneck by using lean tools. And then you need to hardwire this by making the changes a habit, by instilling rewards, software, and analytics and AI that will help you to permanently remove the bottleneck and keep your hospital and emergency department flowing smoothly. So the results you can obtain from instilling this type of system are rapid and they are significant. So this is the emergency department length of stay. We dropped it by 2 hours for admitted patients and 1 hour for discharge patients. This is like adding 280 staffed bed hours per day, which is like adding a fully staffed 12-bed ED pod. This was rapid. This improvement occurred, and it was palpable. The staff felt much less stressed and a lot less chaos at the end of the project. We could also treat an additional 88 patients per day, which we did. We were able to drop the patients who left without being seen from 40 a day to 4 a day, and that increased the overall hospital revenue by 9%. This is amazing. It also improved patient SAT scores. Why? Because they were in the department less. They got what they wanted to get in, get out, get treated. Makes anybody happy. So the overall strategy is TOC. When I first heard about TOC, a million light bulbs went off in my head, literally, honestly, because the goal of the system is what we need to focus on. But a lot of times in healthcare, we don't focus on what is the goal. And it turns out that there's only a few bottlenecks in the system keeping you from meeting that goal. So if you identify these bottlenecks, if you remove them, and if you sustain them by putting measures and metrics in place and manage them, you can actually remove them. What am I talking about? Well, the tenets of TOC is that for the bottleneck, you prioritize the use of the bottleneck. You never leave the bottleneck idle while work is waiting for it. Take, for instance, beds. Inpatient beds sit empty 4 to 8 hours at times when we have ER patients boarding in our ER that can't get upstairs. So we have to prioritize the use. It doesn't remain idle. We offload it. We turn it over. We clean it. We maximize its efficiency. When patients are in the bed, we actually make sure things are happening and they're not just waiting in that bed and camping out. We put metrics in place to actually measure and monitor those bottlenecks. Specifically, we currently don't do that. And we focus management on the bottleneck. We use the metrics to actually alert management when it's time to take management steps and when it's time to problem solve. And by removing the bottlenecks and enhancing flow, it enhances flow through the entire hospital system and offloads the ED, it offloads PACU, it offloads all of the systems in the hospital just by getting everyone to work together as a system and solve our problems together. It's great at team building. We need to identify the bottlenecks. That is the first step. The biggest piles of inventory or patients are always sits before the bottleneck. And flow is the issue, identifying which resource is the most often causing the bottleneck is causing the most disruption in flow. And by removing the bottleneck, the throughput of the entire system's improved. So we need to improve flow of work through the limbo step here. That's where the pile of inventory is. The pile of work, the pile of patients. They're waiting for a CAT scan. They're waiting for labs to be drawn. They're waiting to be actually placed in a bed. The bed is occupied because it is being occupied by a patient that needs to be offloaded. So we need to improve the flow through that step, which will improve the flow through the entire system. We don't need to improve the in and the out. improving them will do nothing to the system. We need to improve the limbo step or the bottleneck. Metrics can also help you to identify problems. It really doesn't identify the bottleneck, but it can give you a sort of a benchmark to where you're at. And it's important to note these throughput metrics, the length of stay metrics, actually deal with capacity. I cannot improve door to doctor time, and I cannot improve without being seen truly by themselves without improving the capacity. So the most important thing to do is to fix the capacity issues by improving flow through the bottleneck. So let's look at the data graphically. So this is the arrival pattern, and I like to look at it starting at day shift, going through evening shift, and then night shift. Why? Because what happens during the day shift influences all the other shifts. If I have backups that occur early in my day, it's going to affect the entire 24-hour shift and even flow into nights. So we can see our arrival pattern happens, and we peak around 10 a.m. to noon. And then we have another peak just after dinner. And if you ask staff when is it the busiest, they're going to tell you it's evening shift. Why? Because that's when they notice the pileup of patients. That's when they notice the wait times in the lobby for patients to get back to a bed and see a doctor is the longest. And this is how what happens on day shift actually affects evening and nights. Because I still am waiting over 60 minutes here, and yet my arrival patterns dropped off dramatically. So you ask yourself why, and you look at this admission census. This is the number of patients occupying the ED beds that are waiting to go upstairs, waiting to go through the admission process, which is a 3-step process. But it takes hours. It takes 4, 6 hours for our patients, once we have admitted them, to get them out of the ED. Why? Because the upstairs unit beds and the med-surg beds are actually occupied by patients, and they're turning those beds over. And it takes 6 to 8 hours to turn over an inpatient bed. This is why our system is backing up, because we do not manage our bed constraints efficiently. Another graphic I like to look at is the census of both the ED and admitted patients in the ED. So here's a 52-bed ED, and here we can see that by noon we are over capacity. The number of patients above this bar, the number waiting in my lobby or in hallways or whatever, waiting to go upstairs. And you can see that we're over capacity most of the day, and you can see the impact of this admission queue. The fact that the admissions pile up and they take forever to get out of this emergency department is one of the biggest reasons why. So this shows you why we need to manage our bed resources. I like these graphics because it really helps to get buy-in from other people so they can see what's going on. And plus, if you can figure out a solution, it really helps you to monitor it. So after we identify the constraint, how do we analyze it? Well, I like to analyze it 2 ways. I like to look at queuing theory, which I'll explain next, and I like to do lean Gemba walks, which is actually going to where the work is done and watching how it's done, seeing if there's any way we can improve the processes. So queuing theory is the study of how people move through lines and how long they wait. So people arrive, they wait in a line or a queue, and then they have work done by a person or they stay in a bed. These are the servers. So there's only 5 causes of waiting. The formula includes arrival rate, variability in arrival rate, service time, variability in service time, and the number of people actually doing the work. So there's a formula that actually tells you how long things are going to wait. And this is it boiled down to the basics. I can decrease waiting if I decrease the arrival rate or if I decrease the variability in arrival rate, if I decrease the time it takes to do the work or the variability in the time it takes to do the work, or if I can increase the number of people doing the work or the number of servers or beds that we have. So you can look at a process and kind of see, is the service time too long? Is it taking 10 minutes to triage a patient? Well, let's see if we can cut down that service time. Is the nurse getting up to do a lot of things during the time she is actually doing the triage? Does she have to get up and get supplies? Does she have to get up and get bandages, ice bags? Well, let's make her workspace more efficient so we can actually improve this. That's why I love this formula so much, because you can actually analyze the things that you can control and the things you can't control and figure out how to make the system work better and actually be more efficient for the people doing the work. So this graphic shows how you can use queuing theory along with TOC to remove bottlenecks and the tools needed. So one of the most important things is to make sure you have the right number of people working or the right server capacity. I'll highlight a few of these things. One of the things you need to do is something called demand capacity matching. Make sure that the right people are working when the patients are needed. We once found that housekeeping was not staffed correctly. During the day shift, they had 2 housekeepers per floor, and the turn time was less than an hour to turn a bed from dirty to clean. However, in the evening shift, that went to 3 to 4 hours. Well, that's when most of our admissions were waiting in the emergency department, and we found out that they only had 4 housekeepers in the entire hospital. Well, we shifted some of the day staff to work like a swing shift in the middle of the morning to the evening shift, and actually were able to improve the bed cleaning just by doing simple demand capacity matching. 5S, workspace efficiency, is very efficient. If you notice that a person's workspace is not efficient, like a storeroom, if you walk into your storeroom and you can't find anything, it's most likely because it was organized by somebody in the storage area, not organized clinically. So what we do is we go into a storeroom and we organize it by categories, by respiratory equipment, wound care equipment, urinary equipment, airway equipment. So it's like walking into a grocery store where the cereal is actually in the cereal aisle and not in with the eggs. So by doing some of these things, you can improve server capacity and service time. I'm going to show you that on the next few slides, how we can actually use some queuing theory and parallel processing to actually improve flow. And you always must keep these tenets of TOC, have your metrics in place, and focus management on your constraint to improve its efficiency. So it's extremely important to go where work's done to see where the bottlenecks are occurring. We knew we had a bed bottleneck, but we wanted to see the process of how actually patients were triaged too, to see if there was any opportunity there, because we had a long door to dock times. And so what we noticed is that patients walked in, were handed a piece of paper by the security guard and had to sit down. An hour later, they saw a paramedic. An hour later, they saw a nurse who was very occupied talking on the squad radio and bedding patients, as well as triaging patients through this very large desk. The whole time this patient went unrecognized. This is what necrotizing fasciitis looks like. Big swollen red arm. It could also be cellulitis or an abscess. But this kind of thing is a huge safety issue and needed fixed immediately. And the bottleneck was the actual nurse. Her actually doing too many jobs and not actually triaging patients and having a huge backup. And no one else knew that they were backed up because these patients weren't in the EMR. So nobody could come help because they did not know how backed up she was. So we did it. We put a paramedic out front who actually had a very efficient workspace. While he was doing the vital signs, this registrar quick registered them and banded them, and they went straight back to the nurse and back to a bed, and the door to dock time dropped to 21 minutes. This is called parallel processing when you do 2 things at once. It decreases the number of queues, and we decrease the service time, the variation in service time, and improve their capacity. And we made the nurse's workspace so much more efficient. She sat at a desk right across from the patient, no squad radio, no bed assignment. All she had to do was triage, and it made her so much more efficient and actually cut down on her stress level. So during the midday, the ER can also get backed up, and at times it gets like this, where it's very chaotic and patients are pushed to hallways and only the most critical things are done. Meantime, patients are waiting in our lobby. They aren't being seen. Here's a mother waiting with a febrile child. Who knows whether this is neonatal sepsis or not? We need to get that patient back immediately. However, there's no beds. And this is where it's backed up in the middle of the day. And this is how problem solving occurs. It's basically whack-a-mole where the biggest problems get dealt with. It's the blind leading the blind because they have no data and they're assuming what the problems really are, but they're really not solving them. There's no cooperation with the rest of the hospital because we're in competition with them for staff and for resources. So the person that's really managing this emergency department is this charge nurse who sits at a desk with a screen looking at the EMR, talking on the squad radio, and actually assigning patients. When things get overwhelming, what does she do? Well, she springs into action and she actually offloads the emergency department. Who can go home? Who in the EMR has a discharge icon that can go home? Who has a clean bed upstairs that could go upstairs and be admitted? Where are psych patients that are medically cleared that could actually be transferred over to psych? So she makes multiple phone calls, talks on her Voicera. The ER is totally sludge, and she keeps doing this until she offloads it. And things like this go unrecognized. This is a bed that is dirty and needs cleaned and turned over. It takes about 3 minutes to turn this bed over. However, it's remained empty and dirty because they're so busy doing other clinical important things. We need to focus some of our staff, non-clinical staff, on turning these beds over and refilling them. Offload the nurses. So for years, overcrowding has persisted, worse at times, better at some times, but always overcapacity because there's no measurement, there's no management, there's no expediting, no escalating, no cooperation, no coordination, and no improvement. And many emergency departments are like this because the EMR does not help you to flow patients through the emergency department. So our team had a thought. We remembered looking at this graphic where it shows the census as it builds up and how we actually become overcapacity. However, most of the actions did not happen until late in the afternoon, early in the evening, when we were totally overcapacity and putting patients in hallways. So the thought was, what if we actually tried to decompress our ED when it first started being backed up? Is there any way we could to improve our flow through our patients? And we found that we did. If we actually escalated early, when we had just a few patients waiting in the waiting room, offloaded our ED, if the charge nurse took action early and escalated when she wasn't able to do decompress the ED, this actually improved the flow of patients dramatically. And so we formed an escalation policy based off of this, and I'll show you the 4-step escalation policy on the next slide. So we had a 4-level escalation policy. Levels 1 and 2 were done by the emergency department and were triggered by the number of patients in the lobby or the longest wait time in the lobby. If it was over 45 minutes, the charge nurse sprung in action and offloaded beds. If she was unable to decompress the ED waiting room, she was actually alerted up to her nurse manager, who would finish up her meeting, come out and know that they've done everything they can to decompress the ED, and she would manage the ED. She would problem solve. Hey, triage is super backed up, the bus unloaded. Let me call the educator out of the back and have her come decompress the triage area for an hour. She would notice things like there's an empty bed that doesn't have an empty room that doesn't have a bed in it. And she would ask our young nurses, because our staff is under 5 years of tenure, why is that room doesn't have a bed? And the nurse would say, well, they went to dialysis. And she would problem solve by saying, we don't hold beds open for dialysis patients because they get admitted from dialysis and go direct to an inpatient bed. So let's clean that room, put a bed in it, and get things turning over. And by doing this, she actually built morale by coaching her staff, and actually they knew that she was going to come out when they were crowded. The second 2 escalations are based off of borders, right? The hospital is responsible for decompressing the ED. The ED is the one that admits 75% of our admitted patients, so we need to keep the ED flowing. So the escalation went like this. The ED would escalate if they had 1 border. The nurse managers on the med-surg floors would round, help their nurses discharge, report those beds to patient placement, who would coordinate the cleaning of those beds with the EVS management. The house supervisor is a nurse that actually manages and would help transfers out of the unit if we needed a unit bed. The hospitalist would be alerted and they would actually round on the discharges first and help discharge them because we knew we had a capacity issue. We were over capacity. And if we were unable to solve problems, we actually tied in the CNO and COO who would round and problem solve and could make policy changes on the fly, could see and recognize that we've done everything we can. So where do we need extra staffing? Where do we need some extra help? They were able to problem solve and solve problems very, very rapidly. And this was extremely successful. And the results were amazing. We were able to drop our length of stay. We were able to improve our patient SAT scores. We were able to see more patients and decrease our left without being seen and increase the overall hospital revenue by 9%. Amazing. So we wanted to make sure this project continued. So what was the next step? What was needed to sustain this? Well, it's actually developing habits in the staff and developing some tools for them to use that would make their job a lot easier. So the software system is called CarePulse. What CarePulse does is it has a display that shows all of the bed opportunities so that nurses can easily find beds to place patients in. It also shows the status of the triage area. Are we backed up? How many left without being seen have we had? No medical record system, EMR, Epic, Cerner, Meditech, they don't show this kind of display, don't show this kind of useful data that we need. And it also helps to problem solve. Are we busier today than normal? Have we getting more squads? The thing is you can look at this from your handheld and manage your department or see where things are needed. So now you know that there is a solution to the problem of overcrowding, diversion, and patient harm and staff burnout just by giving them the tools they need to actually manage and get the whole entire hospital involved on solving its problems. So I'm calling you to action. You know there's a solution. You know that your hospital has issues. So let's implement this system in your hospital. Let's focus on TOC and analyze where's the bottleneck? How can we remove it? How can we hardwire the change? And let's sustain it with habit engineering and with software that actually helps our staff to actually manage the department and the entire hospital much more efficiently to the benefit of all stakeholders. So I thank you for your attention. Here is all my information. I do have other videos on YouTube. Here's my contact information. You can call, text, or email me. I thank you for your attention.